I already got an amazing introduction. So I'm going to talk about the physiologic changes of pregnancy, which is a huge topic. And when I was thinking about this talk, I was thinking about, well, how can I make this talk in 15 minutes review the physiologic changes of pregnancy? So we're going to kind of hit some of the high notes, and then I'm going to give an example of how I think about these patients and how you can kind of develop a framework for yourself to think through what is the most risky part of this patient's anesthetic, and what can I do to make it safer for them. So we're going to just briefly review the physiology of pregnancy because it may be some time since you've thought about that, or sometimes since you've really applied it to cardiac patients, and talk about how it relates to labor analgesia and anesthesia for cesarean delivery. We're going to talk about some scoring systems that I find pretty helpful for stratifying patients into risk categories, and then talk about, I think it's a good time to talk about some common cardiac conditions that we see in no matter what your practice really is, academic or private, big or small. You're going to see people come in with a fair amount of cardiac conditions. So we're going to talk about how we can kind of apply a framework to review kind of potential modifications for someone's anesthetic that may be helpful. So just to start by talking about physiology. So we know that throughout pregnancy, and especially in labor and the immediate postpartum period, that plasma volume increases relatively rapidly. This can help or hurt you depending on the cardiac lesion, which is kind of unfair. So you can't just say, oh, this is always good or always bad. But it helps to kind of think, okay, I know this is going to happen, and what do I think is going to happen based on what this patient looks like to me or what I know they're coming in with. For me, I think it's very helpful to consider the effect of the patient's heart rate, either what their heart rate is going to do during pregnancy or what I may do to their heart rate with my anesthetic or my medications, so like a test dose. Is this patient going to be, if I give them an intravascular test dose, am I going to do something kind of terrible to them? And should I consider using a different test dose in that patient? And then always consider the effect of decreased SVR, obviously most common during cesarean delivery, but really shouldn't be overlooked that if you have these patients that you're planning a labor analgesic on, maybe this is a patient where you're a little bit worried about what's going to happen when you decrease their SVR, and you want to slowly dose their block or put a pre-block arterial line in them or something like that. Not that you don't want to do anesthesia for that patient, but maybe we can make it a little bit safer. So we're going to kind of stick around the cardiac output, heart rate, and plasma volume changes that we know all really, really increase throughout labor, the delivery period, and then the immediate postpartum period. So thinking more in an anesthesia, kind of what do I do for the anesthetic for this patient? I like to start by thinking what happens when I decrease the preload in this patient. So that helps me figure out how closely do I need to monitor this patient's blood pressure. Is this somebody that I think needs an arterial line only if they have a cesarean? Or is this someone that needs an arterial line if they're going to have a vaginal delivery? Because I'm really, really worried that this patient is quite preload sensitive. And then I think very helpful to think about early, what do I do if there's a postpartum hemorrhage? That's usually a kind of abrupt decrease in preload. And is that patient going to tolerate that? Or do I need to know maybe before they're at a liter of blood loss, I need to start thinking about things when they're at 400 or 500 cc's because they're actually not going to tolerate a liter of blood loss over a short period of time. And then I think for us, what happens when the heart rate changes? For me, number one, is a standard test dose safe? And I will say the answer is almost always yes for me. This is a little bit of a nice practice variation that a lot of people have. You all may know that there's a lot of talk about test doses, whether people use them or not even, and then what's in them. For me, I almost always give a normal test dose if I think a patient is safe to receive a test dose. And then are there unsafe medications that may be given not only by our anesthesia team? So we think about uterotonics, but tocolytics, really, really important. And then anesthetic meds. For something I think about is, can this patient have an emergent delivery? Am I going to hurt them with anesthetic meds in a dose that may be unsafe for them? And what happens after delivery? Is the risk period over, or does that patient actually experience a little bit more risk in the immediate postpartum period? And how do I communicate that? So as a good anesthesiologist, we always think what happens in an emergency. So for me, I differentiate between maternal cardiac emergency and obstetric emergency. For a cardiac emergency, I think it's helpful for many of these patients to think, is this a patient that ECMO is going to help? So a patient with pulmonary arterial hypertension, something like that. If the answer is 100% yes, and you don't have that, you may want to consider, should this patient be in a center an expert center where they actually do have access to that? If I think this is one of the kind of highest risks that they might experience during the peripartum period. But more commonly, we're thinking about obstetric emergencies. So what do I do if I have an epidural in this patient and I get called because she's having a terminal decel? It's important to decide whether a stat delivery is possible, and not only decide, but communicate that really clearly with the group. So communicate that with the patient, number one, and the obstetricians. It is at times not safe to do a stat cesarean delivery on a patient, and it's not unreasonable to say, hey, if you guys think the tracing is just not looking right, can you call me and we can have a discussion about kind of how we're doing and where we go from here, opposed to getting called, for example, a patient in labor with severe mitral stenosis and getting called for a true stat delivery, which is probably not a safe thing for that patient or the fetus. So for the kind of purpose of this talk, I would argue that delivery is not really going to help you in a cardiac emergency. And many times it's a sign of worsening cardiac disease, and stabilization is where you kind of need to move. But for obstetric emergencies, we really need to kind of think about, okay, what's my contingency planning here, and how am I going to keep this person safe if something unexpected happens? So risk stratifying patients can be very helpful. There's many scoring systems. The three most common in cardiac OB is the CarPreg-2, the Zahara, and the modified WHO. The first two there, the CarPreg-2 and Zahara, they give you a percent estimate of risk. They're a little bit different in that the Zahara score is a bit more focused on congenital patients. So some of those patients the nuance associated with them is missed by the other two scoring systems. And if you want a percent of this patient is this percentage likely to have something happen to them during their delivery, those are great. The WHO scoring system doesn't really give you a percentage, but it does give you a little bit of a gestalt of how risky is this pregnancy going to be for this person. So you can see that it starts off with WHO 1, which is patients that almost always do totally fine, and moves to WHO 4, which is really pregnancy contraindicated in those patients. And all of these patients, for us and honestly around the country, should have a discussion of whether they want to continue with their pregnancy, because we know that there's a very high risk of something happening to them during their pregnancy or immediately postpartum. At the least, they should be in an expert center that's very used to dealing with patients like this. So we're going to talk about some things that are common. So hypertrophic cardiomyopathy, mitral stenosis, a severe LV dysfunction, and aortic stenosis as well, just to kind of work through how we think about these patients. So we know that pregnant patients with aortic stenosis have a relatively increased risk of maternal cardiac complications. Most commonly, they develop heart failure and arrhythmia if they're going to come in the antepartum period. We know that risk, as you can imagine, increases if they have severe aortic stenosis compared to someone with mild or moderate. We know that their gradients are going to worsen throughout pregnancy because of all the things we talked about: increased plasma volume, increased heart rate, things like that. And we know that those patients have an increased rate of cesarean delivery. There's always this risk of fetal complications with most heart diseases, and usually it's FGR and preterm delivery. So when I think about how do we provide anesthesia for aortic stenosis in pregnancy, is this patient preload dependent? Yes. A patient with severe aortic stenosis really needs close blood pressure monitoring. And if you're doing a cesarean for a maternal indication, for maybe it's a repeat or the patient has a breech fetus, you should really consider a low dose CSE. We can talk a little bit about exactly what that means, but lots of people call those kind of cardiac style or cardiac CSEs. What happens to this patient when the heart rate changes? It's really preferable to avoid tachycardia and maintain sinus rhythm. I do a standard test dose in these patients, though, and that's with a very rigorous aspiration and a very kind of close monitoring period afterwards. Are there common medications that I should avoid? Yep. I would say that for these patients, you should avoid things that induce tachycardia or have the potential to induce tachydysrhythmias. So for me, this is a patient that shouldn't get terbutaline. And we can use other things like nitroglycerin to relax their uterus should they have uterine tachysystole. But I think it's important for us as the anesthesia team to kind of communicate that to the obstetricians that, hey, you may kind of reflex give this medication. Because of this patient's cardiac disease, it's maybe not the best choice for them. Will additional monitors help me, or am I just going to put monitors on this patient to make myself feel better? For this patient, yes, they should have 5-lead ECGs even during labor, which is not a low bar for me because that's really annoying for people to have on during labor. I don't want to do it unless I think it'll actually clinically help me. And then maybe they need an arterial line based on the severity of their disease. They may develop arrhythmias after delivery. That's one of the most common things that we see. So mitral stenosis, just like in the rest of anesthesia, is terrifying in obstetrics. Fortunately, it's a relatively low proportion of valvular lesions, but we know that it impedes blood flow into the LV, and if you really have bad mitral stenosis, you can increase your left atrial pressure and cause pulmonary vascular congestion and pulmonary hypertension, which is a pretty inconvenient thing to have in a pregnant patient. We know that it's poorly tolerated in pregnancy because it's just the opposite of all the things that happen in pregnant patients. They really don't tolerate increased circulating volume. They don't tolerate the increased cardiac output, and boy, do they not tolerate tachycardia. So you should expect an early delivery in these patients. This is a patient that was immediately postpartum that came in with new diagnosis, severe mitral and actually severe aortic stenosis. And these are images from shortly after her delivery when she had her double valve replacement. But you can see the kind of traditional hockey sticking and mixed MSMR with kind of a really eccentric regurgitant jet there. So what do we do for these patients? These patients are very sensitive to blood pressure changes, more so than being just preload dependent. These are patients that get an arterial line for me and a very low dose CSE for a cesarean delivery. It's really important to avoid tachycardia. And even for me, I don't do a normal test dose in these patients. I do just take out the epinephrine part because you could really hurt somebody with that much epinephrine if they have really bad mitral stenosis. Again, same thing with the avoiding medications that induce tachycardia. And then afterwards, this is the most dangerous time for these patients, and everyone's like high-fiving each other because we got the mitral stenosis lady through the delivery, but they're gonna develop really substantial volume overload in the first 3 days, and we really have to watch them pretty carefully. So when you think about patients with heart failure, these, again, you're gonna see a common theme that everything really in the 3rd trimester postpartum increases risk for both maternal and fetal poor outcomes. So we think about mostly dilated cardiomyopathy. Peripartum cardiomyopathy maybe is pregnant again or has peripartum cardiomyopathy, a little bit more rare than the pregnant patients we see with dilated cardiomyopathy, and acts a little bit different and really kind of merits its own discussion. And you may be thinking, what about the RV? Some of you that I recognize in the audience know that I love the RV. It's my favorite ventricle by far. But RV dysfunction is really difficult to manage during labor. You can try to avoid all the things that happen during labor that the RV really doesn't like. Hypoxia, hypercarbia, hypotension, really important to avoid increase in PVR. This happens during labor to everyone. These patients, it's important to consider the etiology and mode of delivery, but honestly, most importantly, you should call your pregnancy heart team. For patients that have any sort of RV systolic dysfunction, those patients are not gonna tolerate labor. They're not gonna tolerate the immediate postpartum period. They need an expert center with experience in RV failure during pregnancy. But if you're anesthetizing just somebody that has maybe an LVEF of 35%, these patients may come in and be kind of hypervolemic and need to be diuresed prior to induction, or they may be euvolemic, and they may actually get a little hypotensive after you put a block in them. You may see a baseline compensatory tachycardia that you can't quite figure out. Could be just that that patient has a low EF and is a little bit volume up, or they have a little bit of RV failure on top of it. For me, I try to avoid medications that increase afterload in these patients or increase PVR. These patients get a 5-lead ECG because boy, do they have a risk of arrhythmias, and they have a risk of ventricular arrhythmias, which you want to know about immediately. And for me, if they have a history of ventricular tachycardia and they have a very low EF, they can probably get an epidural in labor on our labor floor, but they're going to get an arterial line just so we can really closely monitor them. So briefly about hypertrophic cardiomyopathy. We see that, I'm sure everyone has seen a pregnant patient with hypertrophic cardiomyopathy. One of the more common things you see, this patient, maybe you can't see that mean gradient, it's 108, or the peak gradient's 108. This patient had what's called dagger sign and also had a spinal for her cesarean delivery. So these patients generally, they love being volume up. They think it's great. They love the increase in cardiac output. They love the circulating volume, and they usually do totally fine. So not as much of a concern with these patients. It is, I do a spinal in most of these patients, but I do preload them in the pre-op area and then co-load them when I put a block in them. Reasonable to consider a CSE or a lower dose in these patients very, very safe. So for me, the takeaways, I use scoring systems all the time to help guide my planning and help communicate risk to people. It's important to know your high-risk conditions. This is different at every place. So for us, we take care of a lot of patients on the labor floor, opposed to laboring them or delivering them in the ICU, which is almost a never event for us. But it's helpful to have a list of conditions where you think, hey, I'd like a cardiac anesthesiologist to be here for this. Pulmonary arterial hypertension, very severe left-sided stenotic lesions, reasonable to at least have somebody involved. Important to know your L&D floor. You may not be able to have an arterial line on your L&D floor. We can. We can't run inotropes. So you may be able to do that. We can't. And if you know kind of where the patient falls in the risk algorithm, you can anticipate the need to alter your delivery plan or delivery location to a cardiac OR. That's very institution specific, but reasonable to kind of try to figure out beforehand. And then consider a patient that might need to recover in the ICU. So the patient with mitral stenosis, you're really worried about her afterwards, that patient might need to go to the ICU and have a discussion with the intensivist about, hey, this is what I think is going to happen to this patient 72 hours postpartum. I'm really worried that she's going to be very volume up because they just might not be as familiar with pregnancy physiology as you are. That was a lot of information. Thank you for listening, and I'm happy to kind of answer questions at the end.
It's not working. Is it entered? Oh. Sorry. It's not.
This is your mouse here. To move this one around.
Okay. Oh, maybe that's easier. Okay. Sorry about that. Technology issues. Lori, thank you for the introduction. Kate, great presentation. So we're going to be talking about maternal cardiac arrest. This is, sorry. I can move.
I just used the mouse over the little arrow. It was the only way I could get it to work.
Like this one?
No.
Oh, here, those.
Mouse. You can do it. You should.
Okay, what did you do?
I just
Oh, okay, good, we got it.
up and down here.
Sorry about that. So maternal cardiac arrest is a catastrophic event that some of us may encounter at some point in our career. So we're gonna start by giving you some data about maternal cardiac arrest, its prevalence. So this is an article that was published in the Annals of Internal Medicine in 2000, this is it actually, in 2022. They got data from the US inpatient sample, and they saw that the incidence rate was 13.4 per 100,000 deliveries. The survival rate for the moms was around 69%, and the risk factors was old age, non-Hispanic Black, having comorbidities. Acute respiratory distress syndrome was present in 56% of the cases, and mechanical ventilation was required in 53% of the cases. So interestingly enough, when DIC was involved, then the mortality rate would go up like to 50%. This is another article that was recently published in the Journal of Anesthesiology from the UK. They did an audit in all the UK hospitals from 2021, 2022, and they basically saw that the incidence there was almost 8 per 100,000 deliveries, the maternal cardiac arrest. Hemorrhage was the most common cause, followed by anesthetic-related conditions like high neuraxial block and bradyarrhythmias. So most of the events happened overnight based on the paper, and the care was very good during the arrest and post-arrest, but was variable before the arrest. Phenylephrine may have been contributed based on the authors to bradycardia and to the arrest, and high neuraxial blocks often resulted from unrecognized intrathecal catheters. So you're called in your L&D room, or you're doing your night rounds, and you see the patient is hypotensive, the patient is preeclamptic, she looks at you and she's like, well, I don't feel very well, I don't know what's happening to me. And at some point she rolls her eyes back and she loses consciousness. You check the pulse, you feel nothing. You call for help. Immediately you start compressions, you do not delay that. It's very, very important to assign a timekeeper. And why is that? The baby needs to come out by 4 minutes based on the new recommendations from the American Heart Association. It used to be 5, now it's 4. You stop all the drips. Magnesium can cause cardiac arrest, you stop oxytocin, it's an ADH analog, can cause hypotension, you stop insulin, you secure the airway, and it's very, very, very important that you push the uterus to the left manually. If the baby, if you don't get ROSC by 3 minutes, then it's the time that you look at the obstetrician and you're like, we have to get the baby out. And you start the perimortem cesarean delivery. Sometimes, because of the decompression of the vena cava, you get ROSC. The baby's fine, the mom is fine, not always. So here's like a picture, and that was a real case that I had 2 months ago when I started as an attending at the University of Pittsburgh. So this is a picture of how this should be performed, high quality CPR, as in any other cases. You do not adjust hand position, that's not recommended. And of course, we talked about perimortem cesarean delivery. Now, then, while you're treating everything, you need to have an algorithm in your head what the etiology is. So the American Heart Association has developed this algorithm. A, for anesthetic complications. It could be high spinal. B, bleeding. It could be abruption, uterine atony. It could be retained placenta if it's post-delivery. C, cardiac diseases. Peripartum cardiomyopathy is a big one. Takotsubo, it's something that it's pretty fashionable these days. It happens more often than it used to. D, drugs. We talked about magnesium. We talked about oxytocin. We talked about insulin. E, embolism, amniotic fluid embolism. It's a catastrophic event that can happen not only postpartum, it can happen during labor. And of course, PE, F, fever, if the patient is septic, they have choreo. And of course, G, your usual 5 T's, 5 H's, and of course, H, hypertension, hypertensive disorders of pregnancy. And let's go through a few of those causes. As we said, postpartum bleeding is the #1 cause. We used to say that PPH was defined as 500 cc's after vaginal delivery and a liter after cesarean delivery. Now things have changed. Blood loss of more than a liter, regardless of the mode of delivery, is considered PPH. We do KBL, risk factors, placenta creta, abruption, preeclampsia. The most common cause of PPH is uterine atony. In those situations, all the patients get oxytocin. You should not exceed 45 units because then the patient develops severe hypertension. They can have myocardial ischemia. It's not good at all. Then you give methergin, hemabate, misoprostol. We always say, I always listen to people say, yeah, the patient's hypertensive, don't give methergin. The patient has asthma, don't give hemabate. All these are relative contraindications, meaning that if the patient is having uterine atony, he has to get the medications and then treat the complications because they may die from bleeding. So trauma-related is something that happens. The incidence is 0.05 to 8%. Most of the times it could be vehicle-related trauma or unfortunately can be an intimate partner violence. So every time an obstetric patient comes in with signs of trauma, unfortunately you have to interrogate and see if that may be the cause because it happens more often than you think. So the patient may be abrupting, and sometimes it's obvious because you see that the patient is bleeding, and sometimes it's concealed abruption. So you have to get coags. You have to get fibrinogen, because fibrinogen for all of us, 200 is okay, but for a pregnant patient, it has to be at least 400 or high 300s. You may have to give cryo. You may have to give fibrinogen concentrate. You don't want them to get into DIC and die. It's a never event here in a country like the US. So then, trauma-related arrest, you focus on the mom, obviously. If the patient is Rh negative, you give RhoGAM. So a few things about cardiac diseases. And Kate did a very good job talking about dilated cardiomyopathy, and I want to talk about a bit more peripartum cardiomyopathy, which is defined as, there have been multiple definitions about peripartum cardiomyopathy, but usually we go by the European College of Cardiology that defines as peripartum cardiomyopathy as the new onset of heart failure on a previous healthy pregnant patient that happens at the end of pregnancy until the months following delivery. EF should be less than 45%, and why they're not that stringent with the definition, because it seems like they were missing a lot of patients that were coming to the ED, they were less than 36 weeks of gestation, they would miss, the diagnosis, and that's why they have become like less stringent with the definition. So those patients, so an interesting fact, preeclampsia and peripartum cardiomyopathy go hand in hand. And why is that? The placenta in both of those conditions secretes one protein. It's called protein kinase, SFLT2. There's multiple research published on that, so that's why those situations go hand in hand. Now, Takotsubo cardiomyopathy, it's a situation, it used to happen more in post-menopausal women because of the imbalance of the hormones. It can happen at any time during pregnancy. Usually when the patient comes, they come like with symptoms of acute coronary syndrome. You do an EKG, you see ST elevations, troponins are high. How are you going to differentiate between those two? So here we see, this is from a real patient that I did when I was a fellow, OB fellow. So you see like global hypokinesis in peripartum cardiomyopathy. EF is obviously like very, very low, less than 30%. When it comes to Takotsubo, you see that there's left ventricular dilation and there's basal hyperkinesis. I'm sorry, I didn't have a video for that. And it's also called the broken heart syndrome. So that's how you differentiate. You do echo. And as a matter of fact, the American Heart Association is now working on the new ACLS statement in pregnancy. In 2025, it's going to be out, or if it's not out yet, around end of October, I was reading. So POCUS is highly recommended as a way to guide resuscitation during maternal cardiac arrest. So now, amniotic fluid embolism. So amniotic fluid embolism is a catastrophic event. It's a diagnosis of exclusion. So in your head, you should be having the algorithm A, B, C, D, E, F, G, as we talked about. Why is catastrophic? I've had a couple of amniotic fluid embolisms so far, and I'm relatively new in my career, and we all know from the books that yes, the patient's going to have like respiratory failure, and they're going to desaturate. Well, that's not usually always the case. In the situation that I had like recently, the patient never desaturated. The oxygen levels never went down. The patient was hemodynamically unstable. She arrested. We did a perimortem cesarean delivery. Baby was out. We got ROSC, but then the patient got into DIC and died, but the baby was remained alive. So how are you going? I'm sorry, I was looking at the wrong chat. We're going to talk about preeclampsia, so I apologize for that. Here is the amniotic fluid. So how do you diagnose that? As we said, a diagnosis of exclusion, what are you going to do? You're going to do biopsy of the placenta, and you're going to see in those situations tear of the placenta or tear in the umbilical vein. And usually there's amniotic fluid all over, unfortunately, the patient's body. Here's like a few things about preeclampsia, eclampsia, and HELP syndrome. When I saw that patient, because she was preeclamptic, for some reason, I thought she was having an eclamptic seizure. In those situations, actually, the treatment is MAG, more MAG. You don't give benzodiazepines, you give MAG. Preeclampsia, just definition, blood pressure up 140/90, two blood pressures with 4 minutes, with 2 hours apart. ACOG has eliminated proteinuria from their definition because they were sectioning way too many patients for proteinuria, and that would just have like our severe features that I'm not going to go through now. So sepsis. So sepsis is another cause of maternal cardiac arrest. So in the antepartum is pneumonia, UTIs, choreo. Usually that happens in patients who are not very well monitored. So I've only seen that to a place where I did fellowship with the OB patients who were extremely sick with no insurance. In the intrapartum period and postpartum periods, endometritis, wound infection, and again, UTIs. Treatment, broad spectrum antibiotics. So we talked about that. We said that perimortem cesarean delivery, and we're going to describe it a bit here. So the obstetrician is going to do a midline vertical incision from the pubic symphysis to the umbilicus. They open the uterus vertically, they extract the fetus, clamp and cut the umbilical cord, allow spontaneous expulsion or use of controlled traction, and then they control the bleeding and close the layers. It's interesting enough because during that case, the patient was fine. She was responsive. We started doing aggressive resuscitation, and then we took her back to the OR for a hysterectomy, and we saw that she was bleeding from all the well, the sutures were placed. So we placed her on ECMO. It was too late at that point. So how about, okay, let's say the patient is arresting. Now we have to arrested. Now we're going to think about post-ROSC considerations. If the patient has not delivered and we achieved ROSC, some centers used to do hypothermia. However, the data that we've got so far from the literature is mixed. So they don't see any benefit of hypothermia versus normothermia. So that's not a practice in lots of centers. However, if you decide to cool the patient, and the patient hasn't delivered, as we said, then you need to have continuous fetal heart tracing. Now, post peripartum cardiac, perimortem, cesarean delivery, consider hemorrhage control. They're going to bleed, hysterectomy, as we said. That can be the way to manage the patient. Aggressive resuscitation and cryo, or fibrinogen concentrate, which I think I even like it more, less risk for transfusion reaction. So this is like a paper that was published very recently. And it was published in Resuscitation Journal in 2025. And it talks about the outcomes of the maternal and the neonatal outcomes post perimortem cesarean delivery out of the hospital. And out of the hospital, it could be ED, it could be home, it could be anywhere out of the hospital. ED is considered out of the hospital. So based on the authors, it's they looked into all the case reports that were published. Basically, what they found is as long as premortem cesarean delivery was applied by 5 minutes, by 4 minutes, the baby was out. Maternal survival was 4.5%, and the baby survival was like 45%, and that's what they found. So, key takeaways. Very, very important to know that you start resuscitation. You need to obviously call for help. Make sure you have a timekeeper. It's crucial that you get the baby out by 4 minutes. Make sure there's someone who's trained there to push the uterus on the manually on the left of the patient. Make sure you stop all the drips. Make sure you have an algorithm in your head. It's like in the ICU, you keep treating what's going on, and because sometimes we don't know what's going on, but we need to keep treating. And then it reveals itself. It's very, very important to have like basic POCUS skills because it gives you an idea. Like after that premortem cesarean delivery we did, I looked at the patient's heart. The RV was not doing great. We started inotropes. So it's really important to be able to use POCUS to guide your resuscitation management. And we talked about CPR, we talked about a mnemonic. Thank you very much.
So, our last speaker is Andy.
Thank you. Those were two tremendous talks to follow, so I will do my best. I am going to focus, let's make sure I can actually do this. Okay, so great. I'm going to focus in a little bit on a specific set of conditions. We're going to move outside the actual heart to something that still falls in the cardiac bucket. You guys will see why if you don't already know. So I have no disclosures, and these are learning objectives that I'm not going to spend a lot of time on because I tried to cram a lot of things in this talk. So I actually would like to start by talking about a patient that we cared for at our institution in the past year-ish. She was a 25-year-old G2P0, and she was seen in our multidisciplinary cardiac OB clinic at 27 weeks and 4 days with a history of Marfan syndrome, mitral valve prolapse, and scoliosis. She had a pre-pregnancy TTE on file, which showed normal biventricular function, bileaflet mitral valve prolapse with mild MR, and an aortic root diameter of 4.1. Her aortic root diameter was monitored during her pregnancy and stayed pretty stable, which was great. And so a tentative plan was made for induction of labor at term. Unfortunately, at 33 weeks and 4 days, she presented with preeclampsia without severe features. And so in the setting of the pre-E plus her pre-existing aortic dilation after some multidisciplinary meeting and conversation, the MFM team elected to do a primary cesarean section after giving her a steroid course for fetal lung maturity. And so how to approach this patient, how to think about her, how to manage her during pregnancy is kind of what I'm going to cover during the course, and then we'll circle back at the end to see how she did and what happened and how she was managed. So Kate really set me up well for this, because the approach to these patients is very similar to your approach to the cardiac patients with actual heart issues, but the complication you're looking for is a little bit different. And so you're going to do your risk assessment, you're going to figure out how to manage and monitor them during pregnancy, you're going to figure out what the best recommended mode of delivery is, and then how we are going to manage their anesthetic and what things we really need to be looking out for. But the risk you are looking for is not heart failure or arrhythmia, it is actually aortic complication. And aortic dissection is obviously the scariest of all of these. They already have weakened connective tissue in their blood vessel walls, and the hormonal changes of pregnancy will also impact the integrity of the vessel wall, so it puts these people at an even higher risk for aortic complications. And so that is the big thing that you are going to be looking for. So I was going to do a blitz through the risk scoring system, so thank you, Kate, for not making me do that. But we are going to think about how these aortopathy patients fit into our cardiac risk stratification systems. And so the WHO classification and CARPREG-2 are the big ones that we are also going to think about. And now I can talk a little bit slower because I don't have to get through it all. And so these patients actually tend, so this is kind of a list of all the different modified WHO classes and corresponding maternal event rates that you'll find in the literature. And we're really going to be focusing in on the 2 to 3, 3, and 4 classes. So intermediate increased risk, significantly increased risk, and then that extremely high risk where pregnancy is contraindicated, although as we point out, patients will do what they want and get pregnant, and they don't really care what they tell you. And so how do these connective tissue disease patients, aortopathy patients, fit into this? So this figure is from a recent review on high-risk congenital cardiac conditions in pregnancy. And they kind of listed it out with, again, some of those relevant conditions, and I've circled the connective tissue and aortopathy ones. And so you can see there that our lowest risk in the WHO 2 to 3 category are the Marfan's, or what they call heritable thoracic aortic disease syndrome, which I always stumble over saying, or patients with a bicuspid aortic valve, which predisposes you to aortic dilation, and an aorta less than 45 millimeters. In your increased risk category is moderate aortic dilation, and then this class 4, very scary category, is severe aortic dilation and also vascular Ehlers-Danlos, which is like a very scary thing for so many reasons. We have somebody right now who are waiting to deliver with that. So great. Anyway, and so then the figure on your right, the other figure, is from the CARPREG-2 study, and so that's the one where you actually calculate the risk score and get a number for each person. And so high-risk aortopathy, which they basically define as a combination of those other things that we listed, the Marfan's, bicuspid, with a severely dilated aorta, Loeys-Dietz, vascular Ehlers-Danlos, or people who had a prior aortic dissection or pseudoaneurysm, had about an 18% event rate in the study cohort with an odds ratio of 2.7 for an event during pregnancy. So definitely not low risk, something that should be on everyone's radar when we're taking care of these patients. But depending on your aortic diameter and your underlying disease, the risk may vary a little bit. So when we talk about mild dilation and moderate dilation and severe dilation, what do we actually mean by that, right? Because your echo report is not going to say those words, or it may not say those words. It was actually kind of hard to find specific numbers for the grades of aortic dilation. There's some controversy about whether to use the actual number or to index it to people's body size or their height, because I think we can all recognize that different diameters in people with different body habituses will play out very differently. But these numbers are from the AHA guidelines on aortic disease from 2022. And so they define mild dilation as 3.5 to 4 centimeters. And during pregnancy, that gives you a pretty low risk, 1% or less, of aortic complications. But then you see under the moderate and severe dilation, so between 4 and 4.5, there's a higher risk, but we don't have great data to give a number. It's just higher. We don't know what it is. And for severe dilation, similarly, greater than 4.5 centimeters, the risk is just much higher. But how much higher? I don't know. We don't know. So we just get very nervous about it. Now, it's important to note that these risks that I'm talking about are related to type A dissection, which is obviously the scariest, right? It's an emergency cardiac surgery. It's a high morbidity and mortality, but these patients can also have type B aortic dissections. And so the data on this is specifically for Marfan's, but I think it's reasonable to extrapolate to the other ones that it can actually account for 20 to 40% of peripartum dissections, and it is not really related to your aortic root size. So even in these low-risk patients with that 1% or less chance of something bad happening, you still have to have a high degree of suspicion. If they have symptoms that make you concerned for an aortic dissection, because they can still have a type B dissection, even if they don't have the scary type A one. And as far as timing goes, most of them are going to occur in the 3rd trimester or postpartum, probably when that hemodynamic stress of pregnancy is at its maximum. But your risk is elevated for up to 12 weeks post-delivery as your physiologic changes of pregnancy kind of die down and the body gets out to normal. So even when these patients come in postpartum, they still have this elevated risk. So what are we doing for them during pregnancy? As my colleagues have said for other conditions, you want your pregnancy heart team to be aware of and talking about these patients. You want a multidisciplinary team to be involved about them. Ideally, you're in a hospital with the capability of aortic dissection repair, especially if you have somebody who is greater than that low risk. And probably your surgeon should at least be aware that this patient is out there somewhere. During pregnancy, you do want to do some routine surveillance of the aortic root diameter at least each trimester and postpartum. You're looking for changes and increases in the diameter because an increase in the diameter of your aortic root during pregnancy will also signal somebody who is at a little bit higher risk for a complication. And so you might actually end up imaging more often if you see something that's increasing or might be increasing. If you do need to do cross-sectional imaging, MRI without contrast is recommended over CT if possible to avoid ionizing radiation. But as far as medical management, they recommend that to manage them as you would if they were not pregnant. So follow the normal guidelines for pregnancy and for blood pressure in patients with aortic dilation, and specifically beta blockers, which help decrease the shear stress on the aorta. So unless there's a contraindication, they should be getting a beta blocker even during pregnancy. Most likely this will just necessitate increased fetal monitoring to watch out for some of those complications it can cause in the baby. So this is a question I had after this case. I don't know if anyone else has thought of this. Is there a connection between aortopathy, which involves blood vessels, and preeclampsia, which is also a vascular disease? I could not find any evidence for this. That does not mean it does not exist. It may just not be well studied because the numbers are very low. But the one thing I did find was a study from the European Society of Cardiology, and they have ROPAC, which is a database for cardiac obstetric patients, which really provides us with a lot of great data in the field. And they looked at the association of different cardiac diseases in pregnancy and hypertensive disorders in pregnancy, including preeclampsia. And they specifically found that aortopathy was not a risk factor for developing hypertensive disease in pregnancy in their cohort. And that's probably some of the best data we're going to get because of the database and how widely they have a lot of patients for this. I also couldn't find any studies at all on the relationship between developing preeclampsia and the risk of aortic dissection, because you might think, hey, this is a hypertensive disorder, like, does that increase your risk for a complication? And I just didn't see it at all, and that might just be because the complication is still relatively rare, so it's hard to do a good study on it. In practice, our MFMs typically do not want to expectantly manage a patient like this with aortopathy and aortic root dilation who also develops preeclampsia, especially like the patient we talked about at the beginning who's 33 and 4. And so typically they're not going to be real tolerant. So how should we deliver these patients? Now, with a lot of cardiac diseases, we have found that vaginal deliveries are actually safer and are preferred, even if it seems really scary, like the mitral stenosis and the aortic stenosis. Like, you can still do that. This actually might be one of the few cardiac conditions where a C-section might be recommended just based on their cardiac condition. And it's dependent on their underlying aortic root diameter. And so the first thing you notice, the strength of the recommendation varies widely. As we saw, there was not a lot of evidence as far as what your risk was with different aortic diameters. But in general, what we can say is that with an aortic diameter less than 4 centimeters, a vaginal delivery is still recommended. We think those people are low enough risk that it should be safe to do a vaginal delivery. But with patients with an aortic diameter greater than 4.5 centimeters, so severe aortic dilation, they actually recommend, they say C-section is reasonable, which in real life I have found means they're getting a C-section. They're both nodding. They are getting C-sections. And the reason is what you don't want is a long labor course with a lot of fluctuating blood pressure and fluid flow. You just want to get it all done at the same time and not cause a lot of longitudinal stress on the aorta. But down here in these bottom two categories, these like level 2B recommendations, we don't really know what to do if your aortic root is between 4 and 4.5 centimeters. The best route of delivery isn't really known. Both of them are reasonable, sorry, not regional. And this is what our patient was like at the beginning, right? She kind of varied between 4.1 and 4.2, and so a lot of it really depends on the specifics of the patient's situation and comfort levels at your institution and just a lot of other different things that are going on. And so that patient at the beginning was initially planned for an induction. Once she developed preeclampsia, things changed a little bit and the comfort level with that went down, and so then they switched over to a C-section. So those are just an example of some of the factors that might lean you one way or the other. So how are we going to manage the delivery? And this is geared more towards that C-section in these patients. If they are undergoing a vaginal delivery or an induction, we obviously highly recommend an epidural because that helps smooth out a lot of the fluctuation and the blood pressure issues you might see. But if your patient is coming for a C-section, like our patient at the beginning did, the slowly titrated neuraxial anesthesia, as you would see in other things, is very appropriate. So the modified CSE, which is kind of like a small dose spinal, and then you just do the rest up real slowly with your epidural. And what you really want to do is avoid elevated SVR and also swings in vascular resistance to minimize that shear stress on the aorta. You also want to have your systemic vasodilators ready, which you would not normally do for a C-section, because you might have difficulty controlling their blood pressure, and you might need to bring it down in a way that you wouldn't normally care quite so much about in a C-section. As far as monitoring, I think standard monitors are usually pretty adequate. You can consider an arterial line if their blood pressure is difficult to control and you want a closer look at it, or they're at a very high risk for dissection. And again, you want to avoid methylorgonavine if possible for postpartum hemorrhage. And also just remember to have a low threshold for cross-sectional imaging, so CT or MRI, if there's chest or back pain. Echo is not always the best, even at capturing a type A, because it very much depends on the windows that you're going to get, which may be difficult depending on pregnancy or postpartum and body habitus and that sort of thing. So circling back to that patient, she had a primary C-section with a slowly titrated epidural to avoid blood pressure swings. And her blood pressure was pretty stable, but on the higher side during the C-section, probably like 140s, which was not my favorite when I reviewed the record. And during the C-section, she actually did complain of chest and back pain, which resolved intra-op, but given that when she got to recovery, they ordered a stat echo just to evaluate for type A dissection. They did not see any evidence of that, and she had a normal EKG, but her blood pressure was incredibly difficult to control, as it actually was through her steroid window. They had a lot of trouble keeping her normal. And so she ended up going to the ICU on post-op Z0 for antihypertensive drips. Overnight, she developed back pain, and this time they ordered a CT, which actually showed a type B aortic dissection. And so she remained in the hospital between ICU and the floor for a couple weeks for blood pressure control with a plan for vascular surgery to do a repair in an interval fashion. She actually went to a specialty center, so she did not have this done at our hospital. But per the records, she had a pretty complex operative and post-op course, which was unfortunately complicated by a stroke and AFib and required a long LTAC stay. So not the best outcome for her, unfortunately. In our clinic, we have seen, and you guys have probably seen, a lot of people like this, right, with a connective tissue disease, and their aorta is kind of borderline, and most of them do make it through just fine. This was actually the first one that I had seen that had this complication afterwards. And so I actually thought a lot about what we did and would any of these things have made a difference for her. And some of these are thoughts that came in my head, and I'm not sure if, like the A line, like I'm not sure if that would have made a difference in the end or not. A blood pressure cuff probably would have given us a good idea of what was going on, right? We knew she was hypertensive. We probably should have managed her blood pressure a little more aggressively. Should she have delivered right away, or should she have gotten steroids, right? This is a balance between baby and mom and what's the best for each one of them. But the thing I think would have made the most difference is stricter blood pressure control while she was in that steroid window, because I think she sat there and she was hypertensive for several days. And so that, to me, was the biggest lesson learned. And the other question was, should she have gotten earlier cross-sectional imaging given her back pain in the OR? Now, given that she had a type B dissection, would that really have changed her management, right? We were trying to manage her blood pressure anyway, which would have been what you do for a type B. But there's the potential you could have missed a type A dissection in that interval time. So these are just questions in my head that I don't know that there's a perfect answer for. So wrapping up, just some takeaway points. Patients with connective tissue disorders are most at risk for aortic complications in pregnancy and the peripartum period rather than actual cardiac heart failure complications. And monitoring of the aortic root diameter and blood pressure control are two of the best things you can do to help reduce their risk. They might actually require a C-section, depending on their underlying condition and aortic root diameter. Vaginal delivery may actually not be the best thing for them as we try to push forward with other cardiac patients. And our management as anesthesiologists most focuses on reducing the shear stress on the aorta by reducing blood pressure swings and aggressive blood pressure control.
Very good.
Yeah.
Thank you. All right. We have about 3 minutes for questions. So if somebody has a question, please have at it. Come on now. Somebody's got to have a question. Right there at the mic.
Dr. Brennan, in the postpartum period for the severe MS patients, what's your preferred monitoring tool for filling pressures? Do you put in a swan? Do you do left atrial appendage TTE or left atrial volumes on TTE, or do you use CVP?
Yeah. I love the question about a swan. Almost no pregnant or postpartum patient qualifies for pulmonary artery catheter placement, in my opinion. Now, patients with pulmonary arterial hypertension are the outliers for me. Group 1 pulmonary hypertension, those patients, it may be very helpful. No, it's just like any other rapidly accumulating volume heart failure patient. You're going to see it. You're going to see them have pulmonary edema. You're going to see their pressure go down. You can use something like a TTE at the bedside. If you have people that are trained in POCUS, I think POCUS is a great tool, but I do think it requires some experience. But no, it's just like any other heart failure patient where you just know that they're going to do their volume accumulation a little bit more rapidly and hedge on the end of over being aggressive with your diuresis. And I would recommend against routine PAC placement in all pregnant and postpartum patients.
Another question?
All great talks. Question open to anyone, but Dr. Brennan, since you started off talking about, can you maybe elaborate a little bit more on your cardiac friendly or your low-dose CSE methodology or kind of the approach you take on those?
Let's say what we all, so for me, every patient that gets a neuraxial, so a spinal of any kind, no matter what amount of bupivacaine I put the normal opioids. That's not going to hurt anyone. So those patients for us at our place get 15 to 20 mics fentanyl and the normal morphine, 150 mics versus a little bit of Dilaudid, 0.1 milligrams of Dilaudid is kind of our normal mixture. And then for me, it depends on the patient. So if they have really severe critical aortic stenosis, severe mitral stenosis, they're going to get less than 1 cc, a little bit, just kind of have to look at them. So maybe 7.5 milligrams of bupivacaine for me, and then I'm going to slow dose the rest of it with the goal to dose it over about 20 minutes, which I loudly tell the room because everyone else in the room is going to get a little bit antsy and want that patient to have a block that's dosed up. They don't expect it to take 20 minutes. So I usually just tell people I expect this to take 20 minutes so no one's kind of behind you tapping your foot. I've been in that situation where I've kind of quickly dosed a block and been like, man, I wish I hadn't done that. And there can be a lot of pressure on you, but around 7.5 milligrams is kind of a sweet spot for me.
A lot of my colleagues do what Kate does too. I usually don't do a spinal dose. I have a conversation with the obstetricians beforehand. I was like, it's going to take a while. I usually do a DPE, and then I slowly dose the epidural. That's my comfort level. I know a lot of my colleagues do what, Kate does, but I feel it's like, and I keep telling them, the space is empty, so it's not like they had like a labor epidural, and we're going to have a level like, much later during the course. But if we have time, if we don't have time, then you have to do alternative stuff. But that's what I usually do. DP, because you're going to get a good surgical block. you know, in the right spot, and then you dose it slowly with phenylephrine running plus minus, depending on the run.
Oh,
Yeah,
it's also
yeah,
on,
it's
great.
also-
So I will either do what Kate did with the low-dose spinal if I'm like less worried about them. I really like doing that for HOCM patients just so I don't drop their preload super fast, but I don't think they need like the super slow. But if I want them to be really slow, I do almost what you do. But when I do my dural puncture, I actually put the opioids in the spinal space. So I do an intrathecal CSC, and then I dose the epidural slowly, and I think that helps make it more dense, maybe, and with less intravascular absorption than if I just put them through the epidural. So 3 different options.
How about that? All good options. So
Yeah.
thank you all for coming. We're out of time. Appreciate your attention.
Thank you.